You are welcome to my channel. Today I'll be going through the list of medications you can choose from while handling nausea and vomiting. So, I will not be going into details of possible causes of nausea and vomiting, and I will not be going into details of investigations you must do when you are going to prescribe these medications or when you are going to make the diagnosis of what is causing nausea and vomiting. You can start with non-pharmacological interventions by having the list of triggers and avoid them. You can change the diet or add crackers or add ginger. Still on non-pharmacological intervention, we have to determine the level of dehydration. If the dehydration is severe, we have to correct with appropriate IV fluid. We must assess the frequency of the vomiting. If it is severe enough, we might give thiamine. Pharmacological and IV fluid that's appropriate will continue. Now, before we start picking the medications one by one, we need to know why. There are receptor sites, and there are different medications for each site. For nausea and vomiting, we'll have muscarinic area postrema. We have dopamine area postrema. Histamine is found in the ear. 5-hydroxytryptamine or serotonin, and neurokinin-1 or substance P area. So, examples of medications. Number 1, scopolamine. Scopolamine is a muscarinic 1 receptor antagonist, also an anticholinergic. It is useful in motion sickness, in end-of-life care, and many other situations. I have a full presentation on scopolamine already published right there. Another example would be antihistamines, particularly H1 blockers, useful in pregnancy and vestibular dysfunction. Specific example will include Promethazine, a phenothiazine, and antihistamine with trade name Phenergan. Another example would be Dimenhydrinate, known by many as Gravol, and Diphenhydramine, known as Benadryl, Meclizine as Bonine Antivert. Another example would be the class of dopamine receptor antagonist. Here we have phenothiazines, e.g. Chlorpromazine or Prochlorperazine. Those who are familiar with psychiatric medications will know these to belong to class 1 or first generation antipsychotics. Also Butyrophenones, the same class, first generation antipsychotics, Haloperidol or Droperidol. Benzamides like Metoclopramide, Domperidone, and Benzamide. I have a full presentation on Metoclopramide published here, another one on Haloperidol already published here. If we are not okay with either of those two, we can move on to serotonin receptor antagonist. This will be more useful in chemotherapy-induced nausea and vomiting. And examples will include ondansetron, granisetron, dolasetron, palnosetron, or olanzapine. If you are not okay, you can go to another group, neurokinin receptor antagonist. This will be very good for highly emetogenic chemotherapy. And then you can use a member of the group like aprepitant if you are giving it per oral. But if you must give it parenteral, we can use vosaprepitant. Netopitant could be combined with palnosetron under NEPA, or you give rolapitant. If you are not okay, and depending on the situation at hand, you may use glucocorticoids. Here, dexamethasone will be the best, and this will be helpful in chemotherapy-induced nausea and vomiting. You may combine glucocorticoids with 5-hydroxytryptamine or olanzapine. And if you are still not okay, you can choose from cannabinoids, specifically nabilone or dronabinol. The example will also include benzodiazepines. Here, lorazepam or alprazolam will be helpful to handle nausea and vomiting, but it is going to be better to use this with other antiemetics to produce a synergistic effect. But we need to be extremely careful with the side effects of the benzodiazepine and the other antiemetics we want to use. So we must consider the side effects of both medications before giving them to that man or woman. Now, in specific situations like pregnancy, if it is mild, if pregnancy-induced hyperemesis is mild, then just go for non-pharmacological intervention. Avoid triggers, dietary changes, crackers, or add ginger. But if the nausea and vomiting, that is hyperemesis gravidarum, is mild to moderate, you can add pyridoxine to non-pharmacological interventions. And on top of that, you may add doxylamine. But I will go for the decletine. The decletine is going to be the best anti-emetics or anti-nausea and vomiting in pregnancy. It is a combination of the two above here, that is pyridoxine and doxylamine. You may also go for Dimenhydrinate, Meclizine, or Benadryl. Okay, now hyperemesis gravidarum that is very severe, we need to help that woman and the baby inside, right? We have to determine the level of dehydration. If it's severe, we must correct with appropriate IV fluid. We assess the frequency of vomiting, and we may go for thiamine when it is very severe. Then we'll continue with pharmacological and IV fluid as may be appropriate. Now, finally, in severe hyperemesis gravidarum, the pregnant woman is right here. We can give some of these substances, that is magnesium, calcium, and phosphorus, but you must be sure that electrolyte has been assayed. We must know the value of these elements before giving another one exogenously, so that we don't teach the patient to hypermagnesemia or hypercalcemia, as the case might be. Then you can use ondansetron, glucocorticoids, metoclopramide, depending on the gestational age anyway, promethazine and prochlorperazine. So I would advise, seek words from your pharmacist, better still, from the obstetrician. With that, I've come to the end of this very short presentation as per different antiemetics that we may use under different situations. Remember to share this with other colleagues and friends. Remember to subscribe to my channel. I appreciate it.